admit people as soon as we see them.
Thank you. Okay, well, welcome to the CMDA monthly meeting, and thank you for your persistence for joining us today. We have a great meeting and a lot of important information. So we're going to start off with Joe Tansey and an update from CDPHE. Take it away, Joe.
Hi, thank you all. Appreciate the invitation again, even though it was a little challenging. I guess we all learned a new skill today. It seems like a lot has changed, but then not a lot has changed.
So here's what you have to do. You have to go, forget about the link that they sent you. That doesn't work. So what you have to do is go just directly into Zoom. Just get into Zoom all by itself. And then it says, when, ask what meeting are you going to join? I'm going to give you a phone number, and that's the meeting number. It's 720-490-5079.
All right, as you were, Joe.
Thank you so much, Greg. Go ahead, Joe.
Okay, so, we have started doing recertification surveys. We do between 3 and 4 a week.
Hey, Travis and Leslie, do you guys want me to send this out quickly as a mass email to use that number?
Sure. Thank you. Thank you.
Oh, I already did. that.
But if you want to do it again.
Leslie, I think I can't, let's see. Hang on just a second. Oh my goodness. Oh, what a mess. Go ahead.
All right, Joe, we'll let you take it away. And Greg, if you want to send out another email, we're always grateful. So thank you to everyone.
Okay, so we have started doing some recertification surveys. We've tried to do about 3 to 4 a week. Those seem to be going very well. They are taking a little bit longer many times just because trying to get back into the swing of things. And so we are finding, some of the things we are finding is because everybody's attention has been on COVID, is that we are finding areas of quality of care have sort of been dropped by the wayside. And so we're writing some deficiencies of quality of care that we would not have written in perhaps that necessarily in that home in the past. So just please make sure to talk to your homes about how they need to really start looking at other areas of care in the homes and not just focus on COVID, even though that's difficult not to do that. We're seeing weight loss, we're seeing a lot of, social isolation, all the things that you were seeing. And of course, then we're writing deficiencies for those things. So, we all need to start rethinking about all the regulations and not just focusing on infection control, even though that's still a big part of what we're doing. As of October 1st, we started the new fiscal year for CMS. So in this fiscal year, we do 20% of all the nursing homes in Colorado have to be, will have to have an infection control survey, focused in survey, and that will be in addition to the recertification survey. And of course, we are continuing to do the infection control surveys based on a list that we get from CMS every Friday as well. So those have been about 3 to 4 infection control surveys that we have to schedule for the following week from that list. So infection control still continues to be the norm. Many of the 1135 waivers mentioned in the 1135 waiver are still in effect. So please check those and make sure that you're still following the ones that are out there for that. And then I would just briefly like to talk about CMP grants. CMS has authorized us for some CMP grants to help with visitation. So hopefully that will be posted to our website soon. And those, you can apply for those. And the process should be very speedy like it was for the technology grants, because it just has to be approved by our state board. Margaret, do you have anything to add? I know Margaret said she was here by phone, so maybe she had to go off.
No, Joe, I don't have anything else. No, thanks.
Okay. So thanks.
Thank you so much, Joe. That was great. Thank you, Margaret. Okay, I think we are going to now turn, and I just want to make sure that Doug Farmer is on. I'm hoping.
Yes, Dr. Eber, I am on.
Yay, thank you. Thank you for your persistence and perseverance. So Doug Farmer is, of course, the president and CEO of the Colorado Healthcare Association. I just have to give a shout out to CHDA with enormous gratitude for their collaboration and coordination with CMDA and their willingness to partner with us in every possible way. So we are really lucky. I don't know of a more lucky state than Colorado because we have such a great relationship. So Doug is here today to present COVID and the state of long-term care. We're grateful for you taking the time to share your expertise, Doug, and thank you so much for being here.
Thank you, Dr. Eber, for the invitation and for the kind comments. And I want to let you know that I and our board feel the same way about our relationship with CMDA. We feel fortunate to have so many who are so active in the practice and all that has been happening here, not just during COVID. I mean, that this has existed for a long while before that, but I personally appreciate the relationship also and the opportunity to talk today. So Dr. Eber asked me to sort of give a state of the profession presentation today, which I'm happy to do. Before I do that, I just want to thank you all for the work that you're doing and the work that you've done throughout the pandemic. You know, we've seen a lot of attention and accolades going to so-called frontline workers. And when we see that attention, it's usually focused on ER and ICU professionals, which they richly deserve every ounce of credit they get, but I think it's only part of the story. And I think if you want to see the front lines of the impact of this pandemic, you don't need to look any further than the front doors of a long-term care facility. And you all know this, but we've seen such intense pressure, and the ramifications of your work in particular, I think, has never been more critical. No one's seen more constant change in their expectations than these care communities. And I think between all the federal and state and local governmental entities that have been trying to set out guidance for us, you know, it has been a miracle in my mind that there's been consistent care. And medical directors have just done a fantastic job of cutting through that haze and just ensuring that the best possible care is being given regardless of the circumstances. So if no one else has told you this, I want to thank you for all that you do. I'll talk a little bit about, you know, the change that we've seen, some of the challenges that may be within our control and some that are without our control or outside of our control. And then some of the things I see looking forward to, some of the positives that are out there for us. I think to say that a lot has happened in the last 6 months is an incredible understatement. You know, we started in January, February, hearing about this new unique disease that we may have to deal with. And before we could finish hearing about it, it was on our doorsteps. And we morphed from there into a race for PPE and a race for, you know, getting a firm grip on what new infection control measures were expected. And then again, just trying to follow the directions that were coming out from a lot of different areas and that weren't consistent across the board or that weren't applied consistently across the board. And now we're into this phase of indoor visitation where we have a state indoor visitation and a federal indoor visitation plan. And among other things, conflicting expectations around the use of various types of testing. So I probably didn't share anything there that you all don't recognize already, but that's just sort of to set the table. It has been clearly the most challenging part of my career over the last 25 years, and I suspect it has been for most everyone else as well. Just some of the sort of political and economic challenges that I see ahead for us in long-term care. On a political front, one of the main concerns is around obviously funding to support the profession, and also the issue of liability protection. We've been expecting to see some form of liability protection in the form of one of these bills that have been passed in Congress over the last 6 months. And we really expected to see it in August or September. And then when that fell apart, the likelihood of getting anything done before the election is very, very slim. And so our concern at this point is that just from a political standpoint, we do believe that if Democrats control Congress and the White House, we are very likely to go without liability protection for anything that occurred during the pandemic. Democrats are not interested in providing that liability protection. Republicans are, but unless they can get this through one of these bills that they've been passing, and the next one will likely be the last one, then we are likely without that liability protection. On the flip side, I think if there is still divided government in one way or another, if that means a Republican president or it means a Republican Senate and Democrats in the other houses, then there still is a high likelihood of us being able to get some liability protection. On the financial front, we do believe that another stimulus package will be passed. At this point, it seems more likely that it will occur after the election. And what it looks like will depend on, the outcome of that election, and whether they try to run something in the lame duck between November and January, or whether they wait for a new Congress and whoever the next president is to address it. Will likely shape what's in it. And so we're also looking for significant amounts of funding to be placed back into the provider fund that Congress created that has helped to push money out to skilled nursing facilities and assisted living facilities in particular, but also hospitals. It's the same fund, same pool of funds. And nationally, American Healthcare has been lobbying with others like Leading Age, the American Hospital Association, to make sure that there's an adequate amount of money that Congress sets aside so that HHS and CMS can use that funding where and when they deem appropriate. So we'll continue to push for that and work with our national partners to do that. On the economic front, most economists are really expecting some meaningful economic restriction over the next couple of years, whatever you want to call that. But just for context, our state had to fill a $3 billion budget hole at the end of last session, which was in excess of 10% of the state budget. And they're right now expecting to begin the next coming session in January with another $1 billion hole. And that, it could be significantly lower than that as we see federal programs that have been supporting job continuation and unemployment benefits and things like that start to subside. That could, again, meaningfully impact our economy here in Colorado. And so how that pans out for us most directly is in our Medicaid rate, which, once again, next year we anticipate having to go in and fight to retain those resources. And, by the end of the year on the federal level, skilled nursing will have received grants and subsidies and loans of more than $15 billion nationwide. And while there may be more to come, it likely won't continue at the levels that we've seen over the course of this year. And so that plays into some of the other challenges that we see. We have seen significant declines in census across the state. And I don't have data, but I do have polling on about 50 or 60% of the nursing homes in the state at this point. And we're looking at between 15 and 40% declines in census across the state, depending on the type of business and depending on the location. And that becomes incredibly meaningful for a variety of reasons. You know, we think that until vaccination becomes widespread and some form of consumer confidence in the safety of our centers is increased, we're unlikely to see this census move upward in meaningful ways. And so for these businesses that operate on razor-thin margins, it's a really significant concern about their ability to keep their doors open and then to provide quality care. Some of the other challenges I see, I mean, we have got to find pathways to creating psychosocial well-being. And, you know, rightfully so, we have locked down since the beginning of this pandemic on safety and security because, you know, first do no harm turns into first make sure, you know, nothing is out there creating unnecessary death. And so, you know, I think this generation that comprises most of our residents is resilient, but I don't think anybody's this resilient. And I know all of you see the impacts of that. There are conversations ongoing at the state and federal levels to try and return some level of social interaction to our buildings on a more consistent basis, whether or not we're participating in indoor visitation. And so, you know, I think the impact of that isolation that we're experiencing is incredibly acute and also has a negative impact on the well-being of our caregivers. And that leads me to my next concern, you know, for the immediate future and the long-term future, and that's finding ways to combat burnout. You know, we've been running at a sprint pace for a marathon distance, and frankly, we're just not built for that. We can do one or the other, but both is pretty tough in the long term. And you know, there's concern that we'll be losing some long-standing professionals and leaders, and still need to be able to recruit, you know, the usual high turnover areas like CNA positions. So that's a challenge that we're really going to need to address in the very near future. We've been trying to address it just to you know, help backfill the need for staffing in our centers ever since the very beginning of this, when we were losing staff members to have to stay home and care for their children, or people who are frankly afraid to go into care centers, you know, despite the fact that they entered the profession of healthcare. They got really afraid, and some folks decided that this wasn't an area that they could continue to work in. But we're going to need to not just keep backfilling, we're going to need to be building and developing and helping to create the kind of culture that can have lasting positive impacts on the type of employees that we have in this field. So some good news. I've been talking about, you know, relative bad news or relative fears for the last couple of minutes here. I do think that we're finally nearing a point where the capacity to test is going to be able to keep up with the testing needs. And by that, I do mean PCR tests. I recognize the challenges around other types of rapid result testing, but I do believe that we're approaching a place where we'll have, you know, that 24 to 48 hour turnaround on PCR tests, and that will help us to be able to control what we've seen. It's been one of the most glaring challenges over the last 6 months, but I do think that we really are nearing a point where we can get those test results on a consistent basis quickly. I also believe that there's some room for movement on the indoor visitation issue. You know, we have been working through the inconsistencies between a state indoor visitation policy and a federal one. The federal came out just on the heels of what the state did, and so people have been working to try and figure out how to sync those two things up. I do believe that we'll be able to get there in the very near future. There's some conversations with state officials and also with you know, the folks that participate in the governor's strike force. I do believe that there will be a way that indoor visitation can actually become workable in the not too distant future. I also think we're on a pathway to seeing a loosening of that 14-day admission ban that we've been dealing with since this all began. Have conveyed to state officials anyway that, you know, it's understandable that when new cases pop up in a healthcare setting, that it does make sense to initially clamp down on admissions to figure out what's been happening and why, you know, where the case came from and whether or not it's been contained. But I am looking for a pathway to allow that to be lifted more easily. You know, we've seen a lot of situations where that 14-day admission ban turns into 28 days at the local level, and that's just not viable for the long-term future of a stable skilled nursing environment. We cannot keep having 14 and 28-day admission bans and expect to keep doors open for very long. So I do believe there's a pathway forward on that. I also think some good news is that according to our national association, they believe that long-term care residents and staff members will be given first priority for vaccinations when they're available. They're also leaning toward the side that we'll have a more conventional approach, although at a much faster pace than any of us have ever seen around vaccination development. They do believe that we're not going to be seeing vaccines in nursing homes or assisted living for our residents or our staff members that haven't been tested for safety and efficacy. And they anticipate that we'll likely all be vaccinated by the first quarter of 2021. And again, those are all anticipations. They're based on the information that's available at the national level. And I have our national association has done a very good job of staying on top of what's been happening, and a lot of their predictions have been pretty spot on. So I feel comfortable in that, I guess, guesstimate of when we might be able to see some flattening of this, at least in the long-term care population. They really think it'll take another year beyond that before we have the sort of calm that most of us would like to see in the population at large. But I think that it also does seem that Congress is likely to continue to provide some form of stimulus funding through the Provider Relief Fund, though we don't know how much. I do think that's good news, that there doesn't seem to be an argument that more isn't needed. It's just sort of going to be an argument of how much and how often. And the last thing I would say is that a piece of good news is also the ECHO program that's been announced as a pathway to infection prevention, especially I think for those facilities that lack a corporate clinical team or don't have the backing of a larger structure. You know, those independent facilities that really could use some help and guidance and support along the infection prevention line. And the ECHO program initially will be, you know, a hyper intensive with 16 different sessions for a handful of folks within each care community to work on these COVID specific infection prevention issues. But then after that initial intensive phase, they maintain a relationship with their ECHO hub. And we'll be able to reach back out to them with questions that arise. It's not, you know, as you all know, it's never possible to list out every possibility and every eventuality that occurs in a healthcare setting. And so I think having that access back to this hub will be helpful. I don't think it will be without challenges. The way these hubs are being set up, they're not drawing on the usual long-term care expertise that you might find in someone like Intelligent, but instead going through universities and other places where they believe that the teaching can be done and that the development of curriculum can be done effectively. That's a decision that they made really without much input from the provider community. So I do think there may be some challenges there in understanding the regulatory environment and the restrictions that are placed on providers. And we may see a few hiccups that come along when guidance is provided from an ECHO hub that may or may not line up with federal and state expectations along the regulatory structure. But I do believe that in the long run, this is something that the profession has always asked for, that there be a centralized location, not just for infection prevention, but for any number of issues that the federal government wants to see the dial turned on. And we think it's a way to use this structure moving forward to help drive some of those outcomes that the federal government wants to see and give them another tool besides, regulatory citations, CMP fines, and those sorts of things, to do something that's a little more carrot-oriented and a little less stick-oriented. So I do think that is a potential positive as we find our way out of this pandemic. And last, I just would say, and would be happy to answer any questions, Dr. Eber, if there's time, that I think to succeed, we obviously have to all remain band together. It can't just be, the physicians pushing in one direction and some of the other practitioners pushing in another, and people like myself out talking in other directions. We all have to be on the same page, and we have to be in this together in order to succeed. And I just would close by saying I really appreciate our relationship with CMDA and the opportunity to talk a little bit today. So with that, I'll stop flapping my gums and see if there are any questions I can answer.
Well, thank you so much, Doug. That was fantastic. I completely agree that we all have to be on the same page. We're much more effective that way. And I also want to reiterate what a great opportunity ECHO is. I know that Carrie Levy's working with the ECHO project here in Colorado, and therefore I think it will have enormous possibilities and success. I'd like to open it up to people who have questions. You can either put your questions in the chat or you can unmute yourself. I'm hoping you can unmute yourself. If you can't, let us know in the chat. Any questions? Well, Doug, maybe you've answered them all. I know that the Strike Force and Doug and a lot of the advisors to the Strike Force have been working really diligently in trying to mesh what CMS has asked for indoor visitation and what the state of Colorado has recommended for guidance for indoor visitation. So I know that it feels like that's kind of on a pause, but that will be coming soon, and I think it will be welcomed by our residents. And, I know that providers are seeing weight loss and falls and all sorts of stress from the isolation. So know that that's coming. Anybody else have anything else that they want to ask Doug, or any other questions they'd like to pose? Okay, well, Doug, will you be able to stay on for a few extra minutes just in case anything pops up in the chat?
Yeah, I can stay on for a few minutes.
Okay, thank you. So we're going to go on with the Colorado Dementia Partnership, in which Ann Kokish is a part of, along with Joe Tansey and the Alzheimer's Association. So the Colorado Dementia and Telegen, the Colorado Dementia Partnership has been profuse in its dedication, and we wanted to highlight two tools that you can actually find on the CMDA website as well. And the CMDA website is cmda.us, and thank you, Lee Annenberg, for that great website. So I'm going to share my screen and show you these tools. Let's see here. Okay. Hold on. Let's see if we can. Hold on. I'm going to give me a few seconds here. And let's see here. Let's see if we can do it this way. Okay. So this is the first of these tools, and I'm hoping that if I scroll up and down, you can see it. Can someone let me know if that's working?
Yeah, it's working good.
Great.
It is.
So these are two tools that we're hoping that you share with your colleagues and your staff members and your facilities. What it's hoping to achieve is some sustainability for all of us. It was created with the help of Jessica LeClaire, Dr. Kathy Beekle, and Dr. Leah Watson. And so we have a lot of expertise on these tools. The first one is called Supporting You, Supporting Me. And the second one is Have You Changed? And I'm going to do like a David Letterman top 10 of things you should be aware of for these tools. The first of which is they really do work better when they are coupled with a conversation or an in-service. And so handing them to people really often won't do very much. But talking about what's on these tools can really help people and can provide some support, some calm, some empowerment and connection, and to find some hope. So here is my top 10. I think it's a top 8. So for Supporting You, Supporting Me, the top 4 things I think are important to guide us here is it helps for you, your staff, your residents, and the facility. So you can see that there are 3 columns. And for staff, encouraging exercise, healthy habits, and what you can control, and realizing that you're not alone and reaching out to others, and to consider what you're grateful for. For residents, familiar routines, especially with residents struggling with dementia, are key, and comforting environments, getting outside, favorite activities, and connecting with special staff can make all the difference in the world. When you can't see your loved ones, if you have a special CNA or a special nurse who takes the extra 5-10 minutes and makes you realize that you're important, that is phenomenal, and it can make all the difference in the world. And helping residents find purpose. And then for facilities, providing timely information and providing space to answer questions from frontline staff and all staff, I think is key. And avoiding shame. We're all struggling with this, and PPE is hard to don and doff. And so being buddies to one another and helpfully helping do PPE, donning and doffing correctly, but eliminating shame is a really good, important way to share your knowledge. So now I'm going to share the other, let's see if I can do this. Okay. So the second one is called, oh gosh, I hope this works. Have you changed? Yes, we've changed. So there's actually an error in this that we're just correcting. These two titles on the left-hand side, on the right-hand side are reversed. And so where have you changed? Of course you have. It's a struggle to sustain this level of work and input. So it's important to recharge and unplug, address your anxiety loop. Anxiety is contagious. And then think about the RAIN idea from Dr. Watson. So RAIN is just what you're seeing here. Recognize your feelings and emotions. Allow the experience. Investigate with interest and care what is actually happening right now. And nurture with self-compassion and no judgment. I think that's hard, but I think it's worthwhile. And for staff, reducing unnecessary tasks and emphasizing and demonstrating interdependence. So you have both of these handouts already. They were included on the agenda with the wrong meeting number, but you can still see the all the connections and attachments. We encourage you to share these with your friends and your colleagues. So next, I am going to ask Dr. Gahm to give us a flu update, and thank you.
Yeah, let's see. Oh, good. I'm off mute. And now I've even started the video. Hey, flu is, this is going to be an exciting year for me because I have no idea what to expect. The general view, everything is pretty much quadrivalent now, which doesn't really matter to our population because adding the extra B, influenza B into the vaccine doesn't really help or hurt our patients. They seldom get symptomatic with influenza B and it's not serious. So that part's not bad. But 3 of the 4 strains in the vaccine are new this year. Normally that would mean, okay, there's no natural herd immunity, no community immunity, it'll be worse than normal. So that would be the normal thought, but then enters COVID. And then on the hysteria side is, oh my gosh, you're gonna have flu and COVID. Everybody's gonna die of respiratory disease. It's gonna be a disaster, mayhem, all those kinds of things. And I don't think that's gonna be the case, which is why it'll be a fascinating year for me. There's a thing with all viral infections called non-specific interferon. It's a protein that your liver makes. And really what happens is when you have either when you have a vaccine in that first week, or you have an acute respiratory viral infection, your liver starts pumping out this non-specific interferon, and it's your body's attempt to try to keep other viruses from being able to attach. So as long as there's COVID in the community, it may be more difficult for influenza to take hold and spread as quickly. And the only evidence we have that may happen is that last year we had a pretty active flu season that was going pretty solid, getting ready to start winding down. Then COVID hit and flu just disappeared. It dropped off much faster than predicted. I mean, not just than normal, but much, much faster than predicted. So we'll see. Other things to tell you right now, influenza is about half of what it would normally be this time of year. This is when all the influenza lookout stations start watching for it and report. And usually there's some baseline visits, and a few people with influenza, not many. And we're at about half of what would be normal for this time of year. So that's good news. It's not getting here early yet. If that's still the same 1 month and 2 months from now, that'll be good news. And just as a general recommendation, I sent out my basic flu materials to everybody already. If you didn't get those and you want to fill up your inbox, let me know. I'll be glad to send them to you. But the reality is you can vaccinate staff anytime. Even most of your residents that are under 65, you could do anytime. For your sickest residents and for those over 65, we have a captive audience. As long as they're in the long-term custodial side, they're captive. And I tell people to wait until plus or minus Thanksgiving. I would tell you that my own family members that are over 65, I always tell to wait until mid-December because I want them to peak right before flu season gets here. Because especially over age 70, after 90 days, your antibody levels start dropping off. The last thing I would say is just make sure in all of your facilities that you understand that flu vaccine, and this may be why it's not as effective, why we don't have the antibody responses year to year that we would hope for. It is really temperature sensitive. And we're learning more about this even now as we get to COVID and trying to figure out where these, 100-degree below zero vaccines going to be kept. And I think the answer to that is the 100-degree below zero ones are going to go only to hospitals. We're going to get the ones that are just 4 below zero. But at any rate, they're really temperature sensitive. If you have what are called excursions, so if you drop below 36 degrees and you get down around 33, even for 2 or 3 minutes, you'll start seeing the vaccine crystallize. And then as it thaws, it's inert. If you go above 46 degrees for 5 to 7 minutes, the vaccine starts to denature and become inert. So it is really important to keep that vaccine refrigerated and use it within 2 minutes, 3 minutes of taking it out of the vaccine refrigerators. So my number one recommendation would be bring the patients to the refrigerator. And if you can't, and you got somebody that just wants to get their 10,000 steps in, have them take 2 at a time, do 2 patients, walk back and get 2 more, and don't get sidetracked with conversations on the way there. And that's really it. That's the update. Oh, and one more thing, I did have a request to say, what do I think about the nasal flu mist? Initially when it came out, I was a big fan. After it went through several years of not being able to induce much of an A response, I quit being a fan. I don't think there's a real need for it at this point. If you have people that are just deathly afraid of shots, send them out, let them go get a flu mist. It is approved this year in the right population. I wouldn't give it to the older folks over 65. Those are adjuvant and high dose only. But other than that, I'm not a big flu mist fan anymore. And that's it.
Thank you so much. Do you have a preference between adjuvant and high dose?
I'd love to see us do both. It's so cool the way that the adjuvant works because it's an oil immersion vaccine. You actually get just a standard amount of flu vaccine, but the oil helps it spread out in the muscle layer. So you actually just give a lot more exposure to the antigen that you have there for your immune system to see. If you look at all the data and compare antigen to high dose, they're pretty much neck and neck. But even in seniors where we're using it, you increase the average response from 20 to 25% to the 3 different strains, up to 48 to 55%. I'd love to see us do higher dose, maybe double dose and adjuvant, and see if we could get that number up around 70. That'd be great, but they're different companies and, you know, all the patents and legal stuff, and I don't think it's going to happen.
Another question I hear that I thought we'd love to hear your impression is a lot of people say, well, you said to me last year that if I didn't get the flu shot, I would just have to wear a mask the whole time when I was in the facility. Well, clearly that's the reality right now.
Yeah.
What are you saying to those staff members?
Well, it depends on where they work. In all of my facilities now, they either get vaccinated or they get fired. And I know that that's also true in a couple other chains that are doing the same thing. I think there's a lot less tolerance for, you know, with COVID has taught us, we're bringing it in to our patients. We see that. It's the same with flu. And masks that we're wearing don't do it. I mean, they work for COVID. They don't work for influenza. It is airborne. It's not aerosolized. So it's a different mechanism of spread. And these masks are really just so that people like Dr. Gahm know who wasn't vaccinated, so that I'll know who to harass when I'm in the buildings. But N95s would work if you had to wear a mask and you couldn't get vaccinated, but there are very few reasons not to be vaccinated.
I agree. I think it's really important that we all start having conversations with anybody who has vaccine hesitancy to address their issues, their fears, their concerns. And I think that every facility and all providers should go for 100% vaccination because it's just the right thing to do.
Yeah, and thank you, Dr. Anneberg, who got the adjuvant vaccine and got a really good immune response. If anybody sees Lee, make sure you slap him in that shoulder. I don't know who Spock is or what the title change is, but I like Spock.
They changed you to Prince Influenza is your nickname on the thing, and somebody must have changed me to Spock. I'm assuming Travis is doing that.
There you go.
Does anybody have any questions about influenza, the flu vaccine? Any questions for Doug or about the strike force or about supporting our residents and having them connect socially? I encourage folks that it's still kind of warm outside. We're still doing outdoor visits. I know some facilities are thinking about doing an early Thanksgiving while the weather is warm, to try to get people outside and engaging as much as they can. We owe it to our residents to do as much as we can to facilitate their meaning in life. So anybody else have any other thoughts, questions, or concerns? Even though we started late, we were kind of a quiet group.
I have a question. Lee Annenberg here.
Yep.
On a family call recently, one of the family members said he had myasthenia gravis and had been told by his neurologist to never get a flu shot. Now, I admitted right then and there on the phone that I wasn't the authority to give him the final answer about that. But I offered the thought that maybe he was more immune suppressed and might actually benefit from a flu shot, but he should check it out. And so does anyone, especially Greg, Prince Influenza, have a thought about timing of flu shots in regards to, he gets one of those specialized antibody infusions for his myasthenia, and whether he should get the vaccine before, should he wait 2 to 4 weeks after, or should he completely avoid the vaccine due to his myasthenia? Any thoughts?
Yeah, my thought is he absolutely should get the vaccine. And he's got, again, without flu already here, he's got plenty of time to plan ahead. And I would plan to give it 2 weeks before his next infusion, so that he can be really...
That way he'll get the immune response. And getting the infusion won't make his lymphocytes and stuff forget it.
Correct.
So, yeah, thank you.
Sure.
Thank you very much. I wonder if Joe is still on, and I may have missed this, so you'll have to forgive me. Can you talk about some IJs that are being given recently in terms of different care issues that are not COVID related, or could you, I don't know, Joe, if you're still on, but could you speak?
Sure, I'm still here.
Okay.
We did have an IJ in significant weight loss because there were multiple people with significant weight loss, and the home had not recognized it and had not put an action plan in place. So I think it's just a reminder that need to get some of the take out the IDT meetings and start doing those meetings again that focus on other things besides COVID, and really look at those and address those issues. If they had recognized it and addressed it, they would have still received a deficiency, but it probably would not have been IJ. So just a reminder for those kinds of things. And then a reminder too, because some folks are still eating alone in their room, we need to make sure that there's supervision, and that individuals who do need supervision should receive that supervision. We had an incident where someone was on a special diet, on an altered diet, needed supervision, did not get that supervision, and choked. So, another IJ situation. So we just need to sort of take a deep breath, I think, and maybe bring back some of the common sense of things that everyone has been doing, and start looking at different areas of the resident life instead of the infection control, even though we still have to pay attention to that, and I understand that. But we do need to pay attention to other areas. We've seen, we haven't had IJ, but we've seen increase in falls. And so remember to do those assessments for falls, make sure, again, supervision, and I know staffing could be an issue with some of that. But unfortunately, those things still need to be paid attention to. So those are some of the things we're seeing out there in the quality of care areas.
Thank you so much, Joe. I also just wanted to put a plug in for deprescribing, that it's still a great opportunity to do that. And I think it will help with falls. And if COVID comes back again, which I hope it doesn't, but I think it will, the less medications people are on, the better and easier I think that things will go. Anything else from anybody else? Any other topics, concerns, or questions? Okay. Well, I thank you all for joining us and for being so vigilant on getting on Zoom. It was a challenge. We will have it be easier next month. We look forward to seeing you in November. If you have questions or concerns, don't hesitate to reach out to any board member. And we look forward to seeing you next month. Have a great